Hello, everybody. We'll give it just another minute and then we'll get started. My name is Jessica Deaton with the American Indian Cancer Foundation. Welcome to this webinar discussion on the importance of colorectal cancer screening in Indian country. We appreciate you all joining us today to be involved with this conversation around AICAF's Blue Beads Month or Colorectal Cancer Awareness Month. Before we get started today, we wanted to share that the American Indian Cancer Foundation is a national nonprofit organization that was established to address the tremendous cancer inequities faced by Native communities. AICAF is Native governed, and its board members and employees have an array of experience serving the health care needs of our people. Our mission is to eliminate the cancer burdens of Indigenous people through improved access to prevention, early detection, treatment, and survivor support. Before we get into the panelist discussion and introductions, we'd like to take a brief moment to discuss colorectal cancer data in Native communities. Colorectal cancer is the third most diagnosed cancer among American Indian and Alaska Native men and women. Alaska Native people have the highest rate of colorectal cancer in the world, and American Indian and Alaska Native people are not as likely to have their colorectal cancer found early when it might be easier to treat. IHS GIPR colorectal cancer screening rate for 2024 was only 23.6%, meaning that only 23.6% of individuals that are using IHS clinics for care are up to date on their colorectal cancer screenings. Colorectal cancer in Indian country prevention really matters. Regular screenings are one of the best ways to prevent colorectal cancer. This webinar is the perfect chance to highlight the importance of screening in colorectal cancer, along with how Cologuard can be utilized to get your screening completed. We are excited to announce today that we have 50 $25 e-gift cards. Participants must stay for the full webinar to be eligible to receive a gift card. Gift card winners will be randomly selected and will be delivered to email addresses used during the registration portion. Attendance will be confirmed through the webinar platform. Gift cards will be emailed within 1 week of the webinar completion. As we move through the presentation, please feel free to use the Q&A feature at the bottom of the webinar. We will be saving time at the end specifically for interactive question and answer session. Now I'd like to hand it over to my colleague, LaToya.
Hello, everyone. My name is LaToya Braveheart. I am also with the American Indian Cancer Foundation. Thank you all so much for being here today. It is now time to introduce our wonderful speakers. Today we have the pleasure to hear from Dr. Dakota Bost and Dr. Travail Alice to discuss the importance of colorectal cancer screening along with how to utilize Cologuard. Dr. Dakota Bost is a member of the Choctaw Nation. He grew up and went to high school in Anadarko, Oklahoma. His undergraduate work was completed at UCO in Edmond, after which he went to OSU, College of Osteopathic Medicine in Tulsa, Oklahoma, and graduated in 2011. After completion, he completed his residency at St. Anthony's Family Medicine in Oklahoma City. From there, he went to work at Oklahoma City Indian Clinic for several years and has been with Mercy in Piedmont, Oklahoma for the last 7 years. We also have Dr. Travail Alice. Alice is a visionary leader in medicine, biomedical engineering, and health equity, serving as Senior Medical Officer at Exact Sciences. She has spearheaded sustainable partnerships with communities, providers, and executives to dismantle systemic barriers and advance innovative outcomes in driven care. As the company's trailblazing first health equity director, her transformative leadership established programs to continue to improve cancer outcomes across diverse populations. Dr. Alice holds both an MD and PhD in biomedical engineering from the University of Wisconsin-Madison. Okay, so Dr. Boss, we will pass it to you first to begin your presentation, and you are welcome to share your slides at this time.
Okay, thank you. Give me 1 second. It is telling me I cannot share my screen while other participants are sharing. There we go. Okay, guys, is this coming through okay?
Yes.
Yeah, okay, I was gonna say if it is, I can't see anybody anymore. I apologize. Like they said, hey, my name is Dr. Dakota Bost. I am a family medicine doctor here out in Piedmont, Oklahoma. I wanted to thank everyone for the invite to discuss this. We have a ridiculous family history in my family of colon cancer. And so this is something that, at least in my family, we gets talked about at least once every other month, it seems like. So, but we can go ahead and get started here. So why do we screen? Kind of one of the things that Jessica was talking about is colon cancer is wildly, uh, unfortunately, right? Maybe that would be the better way to phrase it. It is unfortunately one of the more common types of cancers that are out there. It is potentially one of the easier ones that we'll talk about here in a bit on how to screen for. Not a lot of fun, but it is something that we can do. And we'll get into that here in just a bit, but it's very common, third most common diagnosed globally in both men and women. And one of the things preparing for this, I found that was kind of interesting. I did not realize that 1 in every 10 cancer diagnoses in general, right, out of all the cancers that get diagnosed, 1 in 10 is actually colon cancer. And when it comes to things that unfortunately lead to us dying when it comes to cancer, it ranks second in cancer-related death. So this is why this is very important. And also, there has been a alarming uptick in colon cancers in those under the age of 50. If you guys remember way back when, the colonoscopies and colon cancer screening guidelines didn't say we do any of this until about age 50, depending upon family history. And those guidelines have all changed in the last 5 or 6 years. So they're starting to shift towards earlier detection and earlier screening. So how do we screen? There's a couple of different ways that we do. The FIT test is a once yearly test. It's not terribly accurate, but it's if we're not going to do the others, it's an option. Cologuard, the one that we're discussing here, is a lot more accurate. It's done once every 3 years. Both of these tests do involve collecting stool and sending samples back. The third option, right, is the one people have probably more commonly heard about, colonoscopies. They basically can be diagnostic and potentially even uh, treatment options can happen during that whenever we go into uh, find out if there's any polyps, they can remove them, and we'll get into that here in a bit as well. But the Cologuard is the one that we're discussing here, and it's done every 3 years, and it's geared more towards average risk adults. And we'll talk about some things here in a minute that make you potentially higher risk. But moving forward here. So who do we screen? The big one now is everybody ages 45 through 75. Previous guidelines stated 50. Just for screening purposes, they now dropped that down to 45. Beyond 75 years of age, it is basically individualized, and that's something that you would need to determine with your primary care doctor and your GI doctor about further screening. Beyond 85, they don't recommend any further screening. So to kind of rewind back to the first point on here, average risk adult starting at being screened at age 45 through 75. How often do we screen is based on what we find through the screening process, so it can change for everyone from yearly all the way out to 10 years right now. But it gets a little dicier when we start talking about what average risk is. And so an average risk is no family history of colon cancer, uh, and no family history, at least in first degree relatives, of any polyps to be found. So kind of going through this, I learned a few different things as well, and they are getting more aggressive about this. So we start screening everyone at age 45. However, if you have a family history of colon cancer and a first degree relative, mom, dad, siblings, uh, or if any one of those mom, dad, siblings had colon polyps, there's lots of different types, but for simplicity purposes on my end of it, just polyps in general, then they start at age 40 or 10 years before the earliest diagnoses. So if someone was diagnosed with colon cancer in your family with a first degree relative at age 40, you start getting colonoscopies at age 30 then. Okay, so some things we can do to try to prevent colon cancer, just general recommendations, right? Try to maintain a healthy weight, be active, eat a clean diet, fruits, vegetables, whole grains. Limit red meat as much as possible. I'm a red meat fan. However, limiting it is a good idea. And also processed meats, which is something that was some I found through this. Prepared lunch meats literally are now listed as a class one carcinogen that's on the same risk of cancer as smoking for lung cancer, uh, tanning beds for skin cancer. Processed lunch meat is now a level one carcinogen, so you have to be careful about what you pick to eat, as always. And as always, right, minimize alcohol and no smoking. So some things to watch out for, and things that we should kind of keep in mind when it comes to screening, or things to watch out for whenever we should be concerned. Um, Honestly, the first one, rectal bleeding, always, you got to make sure that we don't have any evidence of colon cancer there. Unintentional weight loss, night sweats, abdominal pain, bowel habit changes, right? Alternating diarrhea or constipation. And in men, right, we don't typically see a lot of iron deficiency anemia in men, but ages 40s and 50s for a man with iron deficiency anemia, which is something that you would find after you talk to your PCP and did some regular labs. But those would be indications to maybe consider screening a little earlier. And so I did want to give a pretty, I thought, unique case example that I had specifically with Cologuard. It was on a gentleman. He was 51 years old. He had come in to see me in clinic, healthy. I mean, nothing else problem with him at all. His wife was getting on to him because he hadn't had any colon cancer screening, and she basically had to drag him in because he was otherwise fine. Um, and for all intents and purposes, he looked that way. He had no fever, night sweats, rectal bleeding, anemia of any kind. He really was healthy. His labs looked good. Did not want to do a colonoscopy. He did not have any major risk factors, so we discussed other options, and he was agreeable for Cologuard. So as it turns out, Cologuard came back positive, and so he at that point decided it would be worth to go ahead. We talked, and this is a really good reason to move forward with the colonoscopy then. And on the colonoscopy, they found one polyp, just one. They removed it completely, and otherwise he was fine. Went home, nothing major at all. 3 days later, we got the pathology report back, and it found out that that one polyp had already turned into colon cancer. So it was well on the way for him having colorectal cancer. Fortunately, like we were talking before with the colonoscopy, right? When they go in, if they find a polyp, they can remove it. So it's both potentially screening, diagnostic, and curative. They removed the entire polyp. The margins were negative when we were looking at it to make sure that they got all of it. So literally, he had already developed colon cancer. Cologuard came back positive. He went and got a colonoscopy that found the polyp. Uh, and he was cured. Now, the one thing for him is he has to do colonoscopies once yearly for the first 5 years. But literally, right, it saved his life, or at least saved him a lot of medical treatment that wasn't needed. I mean, he was able to prevent it, and that's why we do the screening. He was terribly relieved, as you might imagine. A little bummed out that his wife, I guess, how do you phrase it? His wife got one on him now, is how he explained it. But otherwise, he was, I mean, incredibly grateful, and just really happy that he got to avoid all of surgeries, chemotherapy, all kinds of stuff. So, But just one last plug. Any questions whatsoever? If I said anything that came off dumb and needs to be corrected, you guys tell me. Ask me, please. And whenever it comes to questions about colonoscopies and what you should do, talk to your primary care doctor. If he doesn't know, he can find someone who does know. Thank you.
Um, Thank you so much for sharing such valuable information with us, along with the important role you play in getting patients to get their screenings completed. Now we will turn it over to Dr. Alice. You're welcome to share your slides.
Hello, everyone, and good afternoon. Thank you so much to the American Indian Cancer Foundation for allowing us to present today on Cologuard. I am Dr. Travell Ellis, a senior medical officer, as introduced. I work for Exact Sciences, now Abbott Cancer Diagnostics, and we are the makers of Cologuard. As Dr. Boss kind of explained, we are here because colorectal cancer is impacting the Native and Alaska American Indian communities way too harmfully. We want to make sure that individuals are aware of not only the need to get screened, but how to get screened. And so I have a couple slides and photos to show you just to kind of seal the information that he gave you in your minds. But also as we move to how do we screen, I want to make sure that that's crystal clear as well. So we talk about polyps. Not all polyp is cancerous, but colorectal cancer usually begins as a polyp. And so if you see here this graphic, it's pretty pictorial, but we start with accumulation of cells. Again, just our bodies change as we age, and these polyps may continue to grow. As the polyp crosses what we call the muscular wall, that's when we start to be concerned about cancer. And it can progress from what we call local disease, so just crossing the wall, to regional disease, so more invagination or more crossing to then hit the lymph nodes, and then distant disease, where it then gets into the bloodstream and travels to other organs. The reason why we screen, and many of you know this, is that we really want to catch this cancer in these stages, where it's local, where it's easy to remove via colonoscopy or surgery before it spreads to other places. Is catching cancer down here a death sentence? No, but the survivorship at 5 years when we catch cancer in like a stage 4 is about 11 to 15%. So some people call themselves the 13 percenters. And when we catch it here in the earlier stage, it's about 91%. And so when we think about our relatives, when we think about those that we love, we want to be advocates for getting screened earlier. If we look at how colorectal cancer impacts the American Indian Alaska Native individual, you can see how it's an overrepresentation in this disease. But the good news is that with screening and with action, we can start to decrease these disparities, not only in people getting the disease, but people dying from the disease. The National Colorectal Cancer Roundtable, it's a roundtable sponsored by the American Cancer Society, supports that we need to screen everyone, 80% of eligible adults in every community. So that means adults ages 45 to 65. We want to make sure that they're aware, we want to make sure that they have access, and that they are getting the screening that they need. To do this, we have some work to do. So you can see we are at 57% for our native populations. The good news is that there are many types of screening. So just to recap what Dr. Boss had just shared, there's stool-based tests or poop tests, or what we call non-invasives. Inclusive of those are your multi-target stool DNA, which is the scientific name for Cologuard, your fecal immunochemical test, or your FIT test, or your guaiac-based fecal occult blood test, or FOBT. All of them have reasonable sensitivity to catch colorectal cancer. They have reasonable sensitivity to catch some of those precancer cells to detect polyps. With non-invasive tests, some things might be missed, but these tests are done either between 1 and 3 years to make sure that you're on top of patients can stay on top of their screenings. Visual tests are your colonoscopies. So a colonoscopy or a CT colonography, which is a CAT scan or a virtual colonoscopy, or even a flex flexible sigmoidoscopy are three different modalities for which you can look inside the colon. Of course, the CT is virtual, but with the latter two, you take the scope or a camera and that's inserted in the rectum to look all along the colon. So the sigmoidoscopy just looks at the sigmoid colon, and the colonoscopy goes all the way down to the cecum. With looking inside the colon, there is the opportunity to remove the polyps, as Dr. Boss said, and you can see the little graphic here to symbolize that. When we think about the screening tests, there are some pros and cons to each, and this is a great graphic to talk about that. So when we think about a colonoscopy, again, patients that are high risk, as Dr. Box mentioned, again, you have a family history, a personal history, you have a inherited disease like Fuchs-Jager's or Lynch syndrome, you currently have rectal bleeding. This is the test for you. It could be done every 10 years or depending on pathology, more frequent than that. It's for, again, patients at high risk as well as those that potentially are average risk. You have to make sure that you as a patient or your patients are getting a full clean out to get the best colonoscopy possible. So that does include the bowel prep, etc. Compared to our non-invasive tests. So again, pros and cons. So with our non-invasive tests, these are for average risk patients, not high risk. And they can be done once a year, so FIT tests and FOBT tests, or every 3 years like Cologuard. Cologuard is different than colonoscopy in that it does not require the clean out to happen. It can be done at the privacy of a patient's home, and their stool sample, again, non-invasive, is sent to a laboratory for processing. Should a patient who does Cologuard or FIT have a positive result from either test, those tests must be followed up with colonoscopy. Again, we want to make sure that we are preventing cancer here. So if a patient gets a FIT test where they test for blood in the stool, or Cologuard where they test for blood and DNA in the stool, if either of those are positive, colonoscopy must follow because we want to get that cancer or potential cancer out of the patient's body. Put another way, again, for those that like pictures, high risk, straight to colonoscopy. Average risk, we have some choices. We could do colonoscopy or we could do the non-invasives inclusive of FIT or Cologuard. So now I get to the fun part to talk to you about Cologuard. Cologuard is indicated for individuals of average risk, ages 45 years or older. Again, should be followed by colonoscopy. There are some contraindications to the use of Cologuard that we can answer at the end of the presentation. But if I don't have any objections, I'd like to continue with talking to you about Cologuard. Okay, let's proceed. So the point is to have something at home that can be able to catch patients' cancer before it develops. Here we have another picture, and this one's a little bit more graphical because I really want you to understand how this works. So as polyps grow, again, they grow from the inside of the lumen they grow from the mucosal wall inside to the lumen. As these polyps grow and develop, they start to slough off or release DNA fragments. And these DNA fragments are found within the stool. And so as the stool passes through the colon to the rectum and outside the body, these fragments are contained in the stool, which is why when we do a stool test like the FIT or the Cologuard, we're able to assess what's actually happening in the changes in the bowel movements. What we're also looking for in the bowel movements is the presence of blood cells. And as the polyps change or progress or get a little bit more angry and spread to nearby tissues, you can see how there's an increase of this DNA and there's an increase in blood. And so the idea is that when we use Cologuard, we're detecting not only for the blood, which what the FIT test does, but we're also detecting these DNA changes, such that we're able to detect better outcomes for patients potentially earlier. So what does this look like? If we look at how the numbers play out, and again, these are not head-to-head studies, but how do the numbers play out for patients? Our FIT tests typically catch 74% of colorectal cancers. Our Cologuard detects about 92% of colorectal cancers, and your colonoscopy detects 95% of colorectal cancers. What's awesome about some of these non-invasives is that should a patient decide, colonoscopy is not for me, I want another option, Cologuard is able to provide great high sensitivity for some of those early cancerous changes, what we call high-grade dysplasia or changes or dysplastic changes into the cells. Cologuard also has a great precancer sensitivity as compared to FIT in terms of how well it can detect those cancers, those precancers that might turn into cancer later. Again, all of these are just to show you pros and cons of the test and how one stacks up against each other. Let's go into some of the nuts and bolts of how one might complete a Cologuard test. So with a Cologuard test, you will get a box. Your patient or you will get the box in the mail. It's sent directly to a home address or even a clinic address. Inside are all the components necessary for the patient to complete the test. That includes the test specimen kit, as well as the probe for which we do the FIT test or the hemoglobin test. So the patient will open their box and remove their bracket. This plastic bracket is, again, found inside the box. The bracket is placed on the commode right under the toilet seat, and the specimen cup is placed inside the bracket. The patient is to deposit one bowel movement, the size of a Snicker bar, so no extra, we don't need to fill it up, but we don't want to underfill. If the patient is currently having diarrhea or menses or bleeding, we don't want that patient to complete their Cologuard at that time. Okay, so after the patient deposits their stool in the specimen cup, they are then asked to use the probe to swipe the stool and put that back into the probe. And then there should pour over the solvent to preserve the stool in the specimen cup. We ask that the patients do not drink the solvent, nor do we want them to put it down the toilet. So no urine goes in the cup, just the solvent to preserve the stool that is deposited. All of this information is found in the handy Cologuard brochures that come inside the box, as well as what we call a quick start guide, which is a pictorial demonstration of all the steps that go into collecting your Cologuard sample. Once the sample is collected, there are two labels inside the box. And I'm going to see if I have my labels because they're not here on the picture. Okay, so hopefully you can see this, but there are two labels that go on side. And this is one of the most important parts of collecting your sample. So the label will have the patient's name, first and last, and the date of collection. And the reason we want this to be accurate is because the laboratory, when they process the test, will look and determine based on this date if the test is still viable. So we want the patients to fill it out the day they completed, place it on the specimen collection kit, and then place it directly in the box. Now, this might seem a lot to have in just one webinar, but rest assured, there are how-to videos available in 12 different languages for patients to complete this test. So the languages include English, Spanish, Portuguese, Haitian Creole. Unfortunately, we do not have a plethora of tribal languages, but another thing that could be done is to put the video on mute and then someone help another person navigate should they not understand the language. The other piece that we want to make sure that patients understand in terms of their Cologuard test being accessible is that the kit will arrive to the patient's home or the clinic via UPS. That same box can be sent back through UPS back to the laboratory. So the patients do not have to pay for that kit to be returned to the laboratory for processing. I'm not sure if the screen share will work, but the box is pretty large. It's about the size of my head, and it comes with everything inside. Were this not a demo, there'd be a label here for UPS. That one's, let's say, to Dr. Ellis at my address. I would just remove that label, and below it would be from Dr. Ellis to Exact Sciences Laboratory. Again, the patients can return the kit by scheduling UPS pickup, dropping off the UPS store, or potentially even dropping off at their clinic where the UPS regularly picks up. Why is Cologuard a good test? Well, not only for, as I showed you, the high sensitivity for catching cancer and precancer, but also each patient gets navigation services when they get their Cologuard test. So what is navigation? That's kind of a fancy word. So the idea that once you get an order from a clinician, your primary care doctor or another doctor, and the kit gets shipped directly to the patient, there's a flow of sequences that happen for the next 90 days for which the patient is touched by Exact Sciences to get that kit back to us so we can process it. It includes if we have a patient's phone number, their email address, and their physical home address, we can send them phone calls, text messages, emails, any way to touch the patient to ensure they are supported in filling out their kit and completing their kit, helping them answer any questions. Again, if they speak a different language, navigating in their proposed language, and then they can get status updates. So that's what you see with this encouragement. The patient is not alone in the journey of completing their Cologuard test. Once the test is shipped, they will get status updates, as will the physician when the results return. Throughout this process, it is a journey, and we as Exact Sciences are a part of it with you and your patients. What we have seen is that when patients complete their Cologuard test, about 77% of people who receive a test return a test. Now, this number can vary by practice settings and or patient demographics because we know some patients are harder to reach. But as was mentioned earlier in the webinar, we're only seeing about 26% of patients getting screened at IHS clinics. Cologuard is now available. So how can we help impact that number to make sure that more patients get screened with the benefit of not only a high quality test that's done every 3 years, but one that also includes navigation to make sure the patient feels supported. You'll see here some of the results of the Cologuard test across insurance types. And so this has proved out over years of how patients respond when they get their Cologuard test, and many are motivated to return it. We want to make sure that our relatives and community members within the American Indian and Alaska Native groups and tribes are supported in returning their test and getting screened for colorectal cancer. This is much higher than what we see with the FIT test. And so we know that many FIT campaigns go on, and hopefully that this option being available can improve those numbers to make sure more patients are touched. So I often get questions about cost. Sorry, I'm just navigating. Okay, so the Cologuard test is covered by all commercial insurances, Medicare, and most Medicaids. The next step, should a positive test happen with the Cologuard test, that follow-up colonoscopy is covered according to the Affordable Care Act for no patient cost, not only for commercial health plans, but also for Medicare. Why is this important? We want to make sure that individuals of American Indian and Alaska Native heritage have access to the best quality tests. Colorectal cancer, as Dr. Boss mentioned, is preventable and treatable. And so if we catch it early, that's the best way to make sure that we can have great outcomes for our relatives and community members. And from a system perspective, we can help you meet your quality metrics. So you'll see here, whether it's in the federally qualified health center that follows the UDS data quality measure or the HEDIS quality measure or the adult core set, Cologuard has been validated and is an impactful way to ensure that we're getting people access to screening. So in sum, we want to make sure that you know that colorectal cancer, being that it's March, is on the rise and it's a deadly disease. We can no longer wait to get people screened. The number of people not yet up to date with screening, while decreasing in some segments, is growing in others. And Cologuard just might be that option to ensure that we can get your patients access to the screening. There's quality metrics, there's reimbursement available. So let's make sure that we're not putting more barriers in front of our communities than we have to, because we don't want anything to get in the way. Thank you for the opportunity to share. And if I can figure out reducing my background, I can actually go through the Cologuard box here online if we have time.
Dr. Ellis, if you want to go ahead and go through the box, I think that'd be great.
Okay. Let's see. All right, perfect. That came off. Okay. So this is what comes on the doorstep. The face might look a little different. We are trying to be more discreet over time of what might arrive at the patient's home or the clinic for the patient. As I mentioned, mine is a demo, but typically there will be a large UPS package address label here. There'll be a tear strip, and then you will then open the box. So everything that is necessary to complete this test is within the box. The first thing that will be opened will be a brochure. That's what the FDA makes us put inside. It's a quite long brochure. It's in both English and Spanish, which is why I highlighted for you the visuals with the YouTube videos that are available on the website. We also have the how do you return your kit. What's important about this one is there is the 1844 number here listed. And I always tell individuals that should they have any questions at all, that is our customer care number and they know everything. They're the best. They have extended hours. And so if you need to reach them after hours, that's where the language support comes in, etc. Okay, so now to the box. The box looks like this. Here is the plastic bracket that comes, again, right for you to place right under your toilet seat. So there's no touching the poop. I want to dispel that myth as well. So this goes right under the toilet seat and down. And then there is a zip locked bag to essentially keep things sanitary. So you unzip, and inside is the specimen cup. So there's the specimen cup. It's pretty sizable, but again, we don't need to fill it up. We just need one candy bar size stool placed in a specimen cup. So the beauty of the specimen cup is that it fits directly into the bracket on the commode. So we ask the patients urinate before they complete their sample, and then they sit and then they have a bowel movement that goes straight into the cup. The next step is to take the probe out and open it. And then you're going to swipe stool one time and then place it back. Again, this was to test for the hemoglobin. We need the whole stool to test for the DNA. You'll then take your preservative solution and then pour that onto the specimen. And then you will seal it up. All right. So as I mentioned in the webinar, this is one of key critical steps are the labels. So you'll put one label on the specimen cup and one label onto the probe. So both need to be completed so that we have adequate records of your sample. The last thing we want you to do, or your patients to do, or your clients to do, is to complete the sample and have to then redo it. We will, of course, send them another one should something be wrong, but we want to make sure that on the first time we give them as much support as possible to overcome the barriers. Okay, so labels in. And what's cool about the box is that inside there's grooves. So the specimen cup sits straight up. The fit test sits in this little chassis. So it's not bouncing around as it transports from the patient's home back to the lab. Zip it up. Close it up. And remove the label and stick it back. Remove the other label, ready to go. These components can all be recycled. So they're plastic components and they can just either be thrown in the trash or recycled. So not to worry about that. I will wait for questions to be put in the chat, but there are a couple resources that I want to share that could also be helpful as individuals want to share with their communities or patients. So in addition to the how-tos, we have these office-based resources and patient-facing resources. So one is a couple brochures and posters that include images of families, of Native families that we collaborated with the American Indian Cancer Foundation on to support that screening is important And screening people who get screened, it's not a death sentence. It's if not screened, not for yourself, for those that you love. Um, and then there's community and screening. We also have posters for the offices with the idea that, 45, we're not going to turn 45 and decide, yes, I'm going to get screened, right? So getting these messages out there, getting people primed and ready so that they know that their birthday is coming, and these are just some of the things we have to do to keep ourselves healthy. The other thing is that all of our materials are literacy audited to the point where we want to make sure we're not using overly big words that will scare people off. Cancer as a word is scary enough. So having things at a fourth grade reading level so that individuals can understand, or individuals in the clinic it's easier to explain to someone else because they don't have to take the time to translate complicated medical jargon. The last thing that has been put in place, and again, you can take some or all of the tools, are low literacy templates, right? So call logs or after visit summaries or even text examples. These are all available to use to help motivate relatives, community members, and patients to get their kits back. We have train the trainer sessions for community health workers and even non-clinical professionals. They don't have to have a formal title of community health navigators, but the 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 leader at the talking circle or the leader at the church or the leader at the hair salon, all of these individuals are part of making sure that we get our community screened, and we as Exact Sciences believe are critical to this equation. The other piece I will say is that we at Exact Sciences believe that individuals, regardless of how much money they make or what they have access to, should have access to a test. And should patients have financial need and be in a family of four that makes less than $130,000 a year, we can ensure that they get support to get a free test. So we do have a patient assistance program for Cologuard to ensure we close the gaps for patients that need financial assistance. Another monetary support that we have is supporting with a focus grant program. And because it's March, the focus grant is open for applications. And so if groups want to apply for a focus grant, the interventions are looking to leverage what we call evidence-based interventions. So the idea of patient reminder systems, community education, one-on-one education, provider feedback, navigators, etc. So all of that can be found on our website. I'll make sure we share that as well. But last but not least, screening is important. And screening with Cologuard is an option, and we want to ensure that patients know that. We've had patients who've had great success, as Dr. Boss mentioned, but even others for finding their cancer early and finding it with Cologuard. And so thank you again to the American Indian Cancer Foundation and our partners on this call and across the nation for the work that you do to reduce disparities, to get individuals of Alaska Native and Native American descent screened, because as we see with the data, we have work to do, but we can only do this together. So thanks.
Thank you, Dr. Ellis and Dr. Bost. We really appreciate you both for sharing. You guys are doing such amazing work, and we're honored to hear from you today. We're now going to shift to our Q&A session. So if anyone has any questions for Dr. Bost or Dr. Ellis, you're welcome to put them in the chat or in the Q&A. It looks like we do have one that or a few that have already came in. Dr. Bost, I see the first question is for you. How can patients advocate for themselves if they receive a result and they're not sure what to do next?
Yeah, absolutely. Is that Carla? Is that who sent that over? Carla, hey, good afternoon, wherever you're at around here. When it's all said and done on these things, ma'am, it's kind of straightforward on the Cologuard test. They come back positive, negative, or kind of what she was talking about with the sampling, either an insufficient sample or something along those lines. So a negative test means that we are good for at least 3 years. Unless, right, we have any one of those weird things that pop up, fever, night sweats, weight loss, rectal bleeding, that changes stuff. But If it comes back negative, we're good for 3 years and we repeat in 3 years. If it comes back positive, then the next step is we move on with the colonoscopy. If it comes back with the sampling being messed up or something along those lines, then they will send you another kit and we just repeat the process. So, and what should happen on my end of it though, right, is I get the results whenever my patients do theirs, and it comes back to me with all the same stuff I just said. So someone should be reaching out to you to let you know the results, good, bad, or whatever else we need to do. So if you don't hear from your primary care team or whoever ordered it, you are not wrong to ask a question. Keep asking until you get your answer.
Great, thank you, Dr. Bost. I think that's really important. Keep asking until you get your answer. I think having those conversations and asking those questions is so important. Dr. Ellis, I think that you may have responded to this in the chat, but questions about, are the tools at a cost? Are the resource pamphlets free? If you just want to kind of highlight what you're talking about in the chat.
Yes. So the pamphlets I showed, the sorry, the after visit summary, the text chain, or the text language, all of that is free. So some things you can access through your sales representative for those that you have them. So the after visit summary, as an example, is through your sales representative, as well as some of the low literacy texts and resources. The pamphlets are available through our health equity team, and our colleague from the American Indian Cancer Foundation put that direct email address in the chat and thread. So healthequity@exactsciences.com, and you can get access to the brochures, as well as if you have questions about, I want to get my community health workers trained or my community health navigators trained, we can also partner on that. And we have what we call health equity field liaisons, that whose main goal is to work with our population health programs to ensure that we're getting access to patients that need it most. So between your sales representatives and your health equity field liaison, we'll get you covered.
Thank you so much. And this one can be for Dr. Bost or Dr. Ellis, or if you guys both want to respond. Why might a stool-based test like Cologuard be a good first screening option for people who have never been screened before?
Yeah, so I can start, and then Dr. Boss can talk about his clinical evidence. On one hand, we know that a lot of patients are hesitant to screen, period, right? Like, offer something, the data shows us that when we offer just one choice, only 38% of patients complete that colonoscopy when one choice is offered. And many times that barrier is just that I don't want anything invasive. I can't take off work. Like, the practicality of that test may limit so many people. And so a non-invasive potentially is a good option because those barriers aren't there. It's done at home. If you are average risk, it potentially is the pass through to say, okay, I can do this. I've seen the kit. It's easy to complete. It has high sensitivity, and it's covered where I can get it paid for. And so, and for a lot of those reasons, and you don't have to clean out, right? So for a lot of those reasons, it's very attractive to do a non-invasive test first, so that potentially you get 3 years if you get a negative answer, and then we can go on living our daily lives.
Great,
No,
Dr. Boss,
I
do
couldn't.
you have
No,
anything you want to?
I couldn't agree more. I mean, right, the most important thing always is you get screened, no matter how we do it. And I don't get to fall into the Cologuard category because of my family risk. I have never seen the Cologuard product beyond just the box whenever they bring it by clinic. I won't lie to you, Dr. Ellis, when you were going through all of that, I got a little on the frustrated side myself because that looks like that would take about 20 minutes. And both of my colonoscopies took up 2 days, prep day, and then just waiting around for the colonoscopy day. And it's an attractive offer because you're done in 20 minutes versus losing potentially 2 days of work or 2 days of anything else that you have to do in life. So again, but the most important thing is you just get screened.
Mm-hmm.
Great
Indeed, good screening.
message. And Dr. Ellis, we have one for you regarding the Focus Grant. Just asking, it says, is the Focus Grant open for organizations to apply at this time? I believe you said it was. Is there anything else you want to add regarding that?
Yes, let me find the there's a request for proposals. There's a whole process. But yes, it is open now. It is open through the month of April. I forget when in May it closes, but and there's 3 tiers for support. So if you're just starting out with your program, there's a 1 tier, and then there's more advanced tiers for more mature programs. Um, and organizations across the US have achieved it. So over the years, you saw the monetary amounts we've given. It is competitive. I will say that, but we've seen organizations do some amazing work in communities just because they had the funds to, support a navigator or support the infrastructure or close a gap of something that they had started but couldn't necessarily get over the finish line. So we will make sure you guys have that request for proposals so you can submit.
Okay, thank you so much.
Mhm.
And this is also open for either of you or both of you to respond to. If a patient has had 3 colonoscopies at age 50 and 60 and age 70, can they graduate to a Cologuard test instead of continuing with the protocol for a traditional colonoscopy?
Yes, if they're average risk.
Dr. Bost is shaking his head for
I
the same
agree.
answer.
I said it just depends upon your family history. So if they're average risk, yes.
Perfect. And we've got one more in here right now. If someone is on the webinar today who has never been screened, what is the one step that you'd encourage them to take after this webinar?
I would say talk to their physician. And if they don't have one, let's get them one, or let's get them at least a Cologuard test through Cologuard.com. I don't want people to walk away doing nothing, right? That's the point of having awareness months is moving to action. Dr. Bass, you have thoughts?
Oh yeah, I didn't even realize you could get one from Cologuard.com. That makes all the sense in the world. But yeah, talk to your primary care doctor. We do a lot of different stuff in the office. First and foremost, right, as a primary care doctor, is primary prevention. And so getting colonoscopies and things of that nature done uh, should be something that you should not have to ask more than once for in a clinic office. If you tell your doctor that you want to do a Cologuard or get colon cancer screening, I said at that point, that's all you have to say, and they should take it up from there.
Okay, and I've got one last question, and then we'll kind of move forward. For our relatives who have never been screened before, what are the most common fears or concerns that you hear that you would want that you want to address, to let them know that they should move forward with screening?
So the data says, one, I don't have symptoms. I'm healthy. I don't need to do this. There's also a very much a fear of the results, whether it's positive or negative. It's just this fear of you could tell me I have cancer and you're going to change my life, and I don't want that. I'm fine. And then the last is just procrastination, of, oh, I'll do it later. I know you've been talking to me about this for years. I've got time. And the reality is that we don't. And so colorectal cancer, although we didn't talk about it here, not only is it impacting our relatives and our community members, but it's also impacting younger people. And so we can't rest on, oh, well, I'll do it when I'm 50, or my grandma had that, or I've got to wait till my next vacation so I can take off the week so that I can, everything can be pleasant. There's tools, there's innovation. We got to not make fear, no symptoms, procrastination get in the way.
Mhm. Yeah, and in my clinic, what I see mostly, especially with colonoscopy, is nobody really wants to go through the bowel prep, and nobody wants to be sedated, and or the ones that don't want to, which is all not fun processes. I can attest to myself, but they're also not the end of the world, and it's over and done with before you know it. When it comes to the Cologuard, the more common thing I see is, like Dr. Ellis had said, is the fear of the result. We all want the negative test because that's awesome. And none of us want the positive test. And the positive test, I tell everyone, does not mean you have cancer. It just means that you could. And so the next step is we go and get it looked at. All right, we do the colonoscopy. There's not one cancer that we have that we know about that is better found later in the disease course. Everything is treated way better early on. And yeah, it's just a matter of just getting it done. And like she was saying, it's wanting to have, and I get all the reasons not to or to be fearful of, and timing and just, but also we do have time till we don't. And that's the I think one of the big takeaways are do the test as soon as you can, just to make sure.
Thank you both so much for sharing this conversation with us and answering questions that have come in through the chat. I think it was really meaningful. I'm going to share my slides again here. If you guys will bear with me for just a second. Okay. Let's see here. And just wanted to share that we do have some Blue Beads merchandise available at our website if anyone wants to make a purchase and support the work that we're doing and wear it out into the community to promote getting screened. We know that that messaging can help remind others that it's important to get the screening done.
Awesome. Thank you for sharing that. And I just want to say, Wopila, and thank you for your attendance and engagement today. And a big Wopila, and thank you to our amazing panelists who were able to join and share their knowledge with us and spread the importance of screening and all the different screening options for colorectal cancer. We want to take this time to invite you back to our webinar next year to let us know if this webinar encouraged or motivated you to complete your screening. Before we wrap up, I want to share an additional incentive opportunity. 10 participants who complete both the pre-survey and post-survey will be eligible to receive an additional $50 e-gift card through Giftogram. Recipients will be selected at random for those who complete both surveys. So completing the surveys is optional and selection is not guaranteed. So feel free to reach out to us at health@acaf.org or visit our website, AmericanIndianCancer.org for more resources. And again, we want to thank you all and we wish you all a fantastic remainder of your week.